But yeah, so I will be in place with him to talk about the management of the wrist stiffness, but especially of the painful wrist. So when we talk about painful wrist stiffness, there is different factors that causes it. And so there are extrinsic factors in terms of tendon, soft tissues, injuries, or even systematic, which is the complex regional pain syndrome. But there's also intrinsic in terms of when you have a degenerated radial carpal joint, the mid-carpal joint, the LUJ joints, which can be primary or secondary, like traumatic, like snag wrist, slack wrist, or even inflammatory wrist arthritis, and of which I'm going to mainly concentrate on this. So we know that for wrist stiffness, one of the major contributors is pain. So sometimes it's like, can we just eliminate the pain? So for conservative, we can give analgesics, but surgical, we often forget that we can do neurectomy, which is the wrist denervation. So this is the anatomy of the wrist, and there are so many nerves around the wrist that you can see, in dorsal and palmar side. So what are the indications for wrist denervation? So do we have to ablate all the nerves as been seen here? And how do we do it? There's so many nerves. Which one should we choose? So for the indications, we think that it is most likely is osteoarthritis, whether it's primary or secondary, osteonecrosis like Kienbock's disease or Priest's disease, or inflammatory arthritis like rheumatoid arthritis, SLE, and psoriasis. We can also think about ligaments injury without osteoarthritis, but most of them, I wouldn't use it as the primary procedures. I would use it as more of adjunct procedures. So in ligaments reconstruction, I may use ligaments reconstruction or repair, but then I will use wrist denervation at the same time to improve the outcome. So actually, the wrist denervation techniques is not something new. It's been described in 1966 by Wilhelms, and he talked about the few different ways of denervate all the nerves. Then subsequently, in 1998, Grisham's actually talked about different techniques in terms of having more smaller incisions in both the dorsal and the palmar side, and then to get the ablation of all the nerves. We don't have to ablate all the nerves, do we? Well, we can use preoperative blockade in terms of using lignocaine and see which nerves is actually causing the pain, and then that will actually may indicate which ones that we should ablate. But if we're going to ablate them, what are the results? You can see that these are the paper that's been published, and you can see that there's a lot of different numbers with a longer follow-up, and you can see that there is significant improvement in quite a number of them. But they do actually may deteriorate, as you can see that the 9.6 years or the 12 years follow-up, you can see that quite a lot of them do improve initially, but they may actually deteriorate gradually. How about partial wrist fusion, denervation? Can we actually not ablate all the nerves? Some people would think that, well, the PIN is a major central dorsal innervator, and the fibrous is central 2/3 of the wrist. AIN is a volar wrist, and then actually also basically innervate most of the wrist. Can we just actually denervate both the PIN and AIN, and what are the results? So this is Berger's techniques, of which you just open a small incision at the dorsal side. You find the nerve in the PIN, and then you open a small incision osseous, and then you go right down, and then you can see the AIN, and then you ablate both of them. So what are the results? Well, if you just do a denervation procedures for AIN or PIN, or AIN plus PIN, it seems as though the results here, most of these results, even though the follow-up is not as long, they seems to have a good result. So maybe in some of the cases, we actually don't need to denervate all the nerves. So what is the study that shows that compare complete versus partial wrist denervation? In a systematic review, it shows that both procedures are actually quite effective in terms of improvement in pain and range of movement. For the complete ones, the reoperation seems to be slightly better, so they don't have as many reoperation, but it's still good in the short term. So, and you can see the complication for the complete ones. The complete denervation seems to be a little bit more as compared with the partial denervation. For the meta-analysis in 2021 in PRS, it shows that again that there is no difference between complete and partial wrist denervation. So it seems as though that they are both effective, especially in short term. So what does that all mean? Well, it means that wrist innervation is a viable option for pain relief of the wrist, especially for the short term. Partial and complete innervations are both effective, but there is relatively poor result for distal radius and fracture dislocation, especially you just do a denervation and you don't actually correct the malalignment. As it can be used for a standalone procedure, but not for dynamic instability. But in a dynamic instability and other, you can actually use it as adjunct to other procedures. We may still need to talk to the patients that it is a by-time procedure, and we may need to have second procedures in the long term. Whether we do a preoperative blockade, I think in the study so far is still controversial. There are studies that shows that there is pro, and then we should do a preoperative blockade and see whether the result, but there are other studies that show that it doesn't really is not predictive enough. So what is my approach? My approach is that we do routine neurectomy for rheumatoid arthritis, because when I'm doing the sinupectomy and the tendon reconstruction, I see the PIN nerve, I might as well just do it, and then that will give a good pain relief. For cases who refuse salvage procedures, it is a quick solution, and for selected case, when I do salvage procedures, I will do a neurectomy just in case as well. So this is a case with rheumatoid arthritis, of which I'd open the dorsal and palmar, and of which I would do a neurectomy at the same time. This is a case that I have a 50-year-old left wrist pain with stiffness. He's worked in the kitchen, and X-ray show as SL dissociation. Unfortunately, when I do a wrist arthroscopy at that time, when trying to reconstruct the SL ligaments, I confirmed that it was actually not. There is some degenerative changes. So at that time, the patient really doesn't want to go for a salvage procedures, so I did an AIN, a PIN neurectomy. So the pain, the VAS score from pre-op, it goes from 5 to 0 at rest and 2 on exertion post-operatively. The patient has satisfactory range of movement and able to resume work in kitchen. 6 years later, unfortunately, he still have a lot of pain. So now, I can have a by-time procedures for 6 years, and then he opted for PRC, which has a faster recovery. So this is the result that I got in the end. So the patient was happy, and then actually he come back to me and said that he wants to do another side where he also have a slack wrist. So with that, I'll just conclude that I think neurectomy, it is very good. It's a good procedure. It can be used as a primary procedures for by-time procedures, but it can also be used as adjunct procedures. We obviously not going to say that, we don't need to do any capsulodesis or any other, but it can be used as adjunct procedures of which the patients tend to have good results. So with that, thank you for listening.